Good morning, ladies and gentlemen, and I would like to thank for that kind introduction that has been given to me. Also, I would like to thank the Eastern Cape IPA for inviting me to talk this morning, as well as Zydus Pharmaceuticals for inviting me here to do this presentation on caring for rheumatology patients in the era of COVID-19. This is going to be basically practice essentials. That is me. And these are my disclosures. I am getting paid for this talk, so I'll make that quite clear up front. Firstly, in terms of COVID-19, let's get through to some of the myths. And Russia's Channel 1 had aired this some time ago, which they said Donald Trump had named it coronavirus to promote his Miss Universe competition, and that is fake news. Myth number 2, which came out from the eastern parts of the world, is that only Asian men get coronavirus. A comparative genetic analysis of novel coronavirus receptor angiotensin converting enzyme receptor 2 in different populations, and it showed that people of Asian descent and Asian men may be more prone to get coronavirus. Nothing is further from the truth. Interestingly, COVID-19 was predicted in 1981. This is a really, really eerie coincidence. However, it is false. Now, when we look at the origin of the SARS-CoV-2, we know it is from bat to mammal to humans, which started around November, December 2019. And pangolins were implicated in the transmission of this virus. And we know that pangolins are used in Chinese medicine. There was a probable link to the seafood and exotic animal market in China, in Wuhan. Other plausible theories include the Wuhan level 4 biohazard laboratory experimental animals were sold for human consumption, or whether the virus leaked from the laboratory. All of these things haven't been proved, but they're very plausible. And a very nice saying by Leavitt was that everything we do before a pandemic will seem alarmist, and everything we do after will seem adequate. This really fits in nicely with our current pandemic, because everything we seem to do at the moment seems inadequate to control the pandemic due to mutations that are ongoing. Now, an overview of my talk, I'll give you a small introduction on COVID-19 in rheumatic diseases. We'll talk about COVID-19 and the risk of infection in rheumatology patients, the current guidance on maintenance and continuation of treatments, practice guidelines for rheumatology patients on DMARDs. We'll put a bit of spotlight on DMARDs, and I'll talk a little bit about vaccination in DMARDs and end with a small summary of the whole talk. Now, I'll start off with rheumatoid arthritis because it's one of the commoner forms of inflammatory arthritis that we see. And we all know that rheumatoid arthritis occurs in patients. We get swelling of the PIPs and MCP joints, as shown in this slide. Just get my pointer there. We can see there's fusiform swelling of the PIP joints on the index finger and the middle finger, and a little bit of swelling on the MCP joints. That slide is quite early in the disease course of rheumatoid arthritis, and this slide is an established rheumatoid arthritis patient where we see subluxation at the MCP joint, ulnar deviation at the MCP joint. We see wasting of the small muscles of the hand, Z thumb swelling of this MCP joint, and swelling around the ulnar styloids bilaterally, and this is an across-the-room diagnosis in a patient with rheumatoid arthritis. Rheumatoid arthritis is often an aggressive disease if left untreated, may have potentially devastating consequences, and early and aggressive management can lead to successful control as well as remission of the disease. On an average, life expectancy is shortened by 5 to 15 years in patients with rheumatoid arthritis. Patients with rheumatoid arthritis are twice as likely to have a myocardial infarction or a stroke, we have increased risk of infection in these patients, not only due to the medication, but also the disease process. And there's a risk of lymphoma, which is 3 times greater than the general population in patients with rheumatoid arthritis. All of these things lead to increased morbidity and mortality in rheumatoid arthritis. And hence, one cannot overemphasize the treatment of rheumatoid arthritis, which should be initiated as early as possible in order to improve patient outcomes. Disability in rheumatoid arthritis, there's an average lifetime earning loss of approximately 50% of the patient's income, and approximately 40 to 85% of patients with rheumatoid arthritis will be unable to work within 8 to 10 years of disease onset if it is left untreated. Now, this is a nice and interesting slide because it gives the pathogenesis of rheumatoid arthritis, and we can see here the antigen-presenting cell, which activates T cells, which then activate B cells and macrophages, which results in elaboration of pro-inflammatory cytokines, especially tumor necrosis factor alpha, which is a pro-inflammatory cytokine that leads to damage and inflammation in patients with rheumatoid arthritis. This is important because of the pro-inflammatory cytokines may also overlap in patients with COVID-19 infection. Another common disease that we find amongst general practitioners is systemic lupus erythematosus. And we see patients with systemic lupus erythematosus may have a malar rash, may have a discoid rash, photosensitivity rash, oral ulcers, which are usually painless. They may have arthritis, serositis, which may be as a result of pleuritis, or pericarditis, or pericardial effusions and pleural effusions. They may have renal disorders or kidney involvement with lupus, neurological disorders, or neuropsychiatric manifestations, hematological, immunological manifestations, as well as a positive anti-nuclear factor. Now, systemic lupus erythematosus is also driven by a pro-inflammatory state, which results in multi-organ failure, not dissimilar from COVID-19 infection. Now, when we look at COVID-19 and rheumatology, there's a large amount of scientific research that has been done at a very rapid rate, considering that this disease is fairly new. And scientific rigor in research have been limited by the overwhelming pandemic, with the result as the strict measures that were undertaken in publishing papers before COVID-19 are slightly laxed during the pandemic, so that more papers are getting published and we learn more about the disease. Now, because of this, the scientific rigor and these papers, more papers coming out may lack quality. That's an important thing. Patients with rheumatic disease have been negatively impacted by the COVID-19 pandemic, as there is uncertainty regarding the risk of COVID-19 infection in rheumatic diseases, uncertainty regarding the risk of SARS-CoV-2 infection due to the therapy that these patients may be on, and there is availability and access to care for patients with rheumatic diseases may be decreased during the pandemic, as most of the physicians are now concentrating on managing patients with COVID-19 infection. There is also a health-related anxiety in COVID-19. Some patients regard the hospitals and doctors as a source of the contagion and avoid seeking medical assistance, with the result that they take over-the-counter medications with the progression of the disease, and they present quite late. Patients may require more health-related information and reassurance to allay their anxieties regarding doctors and hospitals so that they can present earlier to these institutions. Also, doctors are inundated with new developments in a rapidly evolving field that provides quite a challenge to doctors and patients alike. Now, the preventative measures and safe practices for rheumatology patients are similar to that in the rest of the population. However, the British Society of Rheumatology presented a risk stratification for patients with rheumatoid arthritis or rheumatology patients in general, and they weighted their scoring according to the risk of patients on drugs or the disease. So patients taking more than 20 milligrams of corticosteroids per day were scored a score of 3, corticosteroids or prednisone at a dose of 5 milligrams to 20 milligrams per day for more than 4 weeks are scored a score of 2, cyclophosphamide a score of 3, leflunomide, methotrexate either 1 point, or if they're taking a combination of methotrexate and leflunomide, that is scored as 2. Also, if they're on other immunosuppressive therapy, including biologics or monoclonal or small molecules, if they're taking 2 or more immunosuppressive medication, whether biologics and conventional synthetic disease-modifying agents, that's scored as 2. Any of the following, which we know are risk factors for COVID-19 infection and comorbidities: age, diabetes, any previous lung condition, chronic kidney disease, heart disease, and high blood pressure, they scored as 1. And if they're on hydroxychloroquine or sulfasalazine alone, they have minimal risk, and that is scored as 0. So we work out the cumulative score in these patients. And this was at the beginning of the pandemic where the risk stratification was developed, and there were more stringent measures in terms of patients with scoring more than 3 points. They were at high risk. 2 points, they were at moderate risk, and 0 to 1 point, they were at low risk. And these gives an idea of how these patients should be stratified and managed in terms of quarantine and self-isolation. The American College of Rheumatology guidance on general infection preventative measures are similar to that in the general population, including hand hygiene, washing of hands, social distancing, wearing a mask. And what has come into vogue now is telemedicine. Telemedicine has come into vogue in terms of managing patients virtually. And we manage a lot of our patients at the moment virtually to prevent them from coming into hospitals. And delay in initiation or redosing of infusion-based treatment when risk of disease flare is low, we should consider delaying infusions in these patients and managing them out of hospital as far as possible. Now, importance of ensuring disease control during the pandemic, apart from patients being exposed to COVID-19 infection, one has to balance that with their disease activity itself. So it's a balancing act between disease and COVID-19. In patients who are stable on disease, we generally continue treatment. If they're well controlled, hydroxychloroquine or chloroquine, we continue treatment. If they're well controlled on an interleukin-6 inhibitor or what we call tocilizumab, we continue treatment. And including methotrexate and other conventional synthetic DMARDs, we continue all of these treatments. However, when patients have active disease and they have active inflammatory arthritis, we go to with a moderate to high disease activity, we can start newer therapies, including conventional synthetic disease-modifying anti-rheumatic drugs. We can also start biologics, and we can start or change biologics or disease-modifying agents. And for active or newly diagnosed patients, we can switch the medications to more potent ones should the need arise. Also, if these patients have active disease, low-dose glucocorticoids or systemic corticosteroids or non-steroidal anti-inflammatories may be started for symptomatic relief to improve these patients' quality of life, and it doesn't really increase the risk of COVID-19 infection. So implementing of telemedicine, as I mentioned, I alluded to earlier, virtual communication with patients and telemedicine has come into vogue recently. The pandemic has accelerated or focused changes such as using telemedicine to connect our patients. Virtual consults are an everyday occurrence with us now. Telemedicine can also be used to access and triage patients for COVID-19. Apart from treating their rheumatoid arthritis or rheumatological problems, these patients can be triaged for management of the COVID-19 should they be COVID-19 positive. Telemedicine can be used for ongoing management of many chronic diseases, not only in rheumatology, but in other fields as well. It can be expanded to other fields. Evolution of patient assessment in the digital world, appropriate triage of patients for face-to-face versus telemedicine. If patients are stable, then they can be continued on virtual consultation or telemedicine review. However, if they are having active disease and having difficulty with the activities of daily living and facing difficulties, these patients may be triaged for a face-to-face consultation with their rheumatologist. Evaluation of disease activity by remote consultation or virtual consultation is important because we rely on patient-reported outcomes in these patients, because the patient tells us how they're feeling, and we cannot actually measure the disease activity by examining these patients. Which patient-reported outcome evaluation give high confidence of satisfactory disease control and potential red alerts? The jury is still out there. However, the BASDA, RAPID-3, and RAID, which are self-administered patient-reported outcomes, and it gives us some degree of how the patient is doing. Interpretation of these patient-reported outcomes are very subjective. And remember, some of these patients may have fibromyalgia-like symptoms and problems, and this increases their pain, which may give falsely high patient-reported outcomes and misinterpret the patient's disease activity with their rheumatological conditions. Education for patients in self-assessment, it can be done successfully in conditions such as rheumatoid arthritis, provided there is an appropriately selected patient subgroup and it is used in patients who understand the impact of patient-reported outcomes, and it's generally not suitable for every patient. However, that has to be taken cognizance of. Now, some of our patients with rheumatological problems are on intravenous or subcutaneous medications. That poses a problem. If they have to come to a hospital for their intravenous infusions, they increase their risk, especially when there's a wave of disease. And so we need to prolong the distance between these patients' intravenous administration doses so that we can both control the disease as well as decrease the risk of COVID-19 infection. The role for home infusion services are first world, and in the first world setting, they are now setting up patients' homes for infusion services so that they do not leave their homes, and a nurse visits the homes on a home-based care program and administers the infusion at their house, which protects everybody. The risk of COVID-19 infection in rheumatology patients, it's a complex relationship between infections and rheumatology, because we know that rheumatology, most of the rheumatology conditions are immune-mediated rheumatic diseases, and that not only causes a decrease in the immunity, but also therapies that we use to treat these patients to suppress that immune system can both lead to an increase in infection. So there is a vicious cycle between the disease itself, the therapies, and the infection that these patients may get, and we need to balance that very carefully. We are very well aware of the risk factors for severe COVID-19 infection and the comorbidities, including age, gender, hypertension, diabetes, cardiovascular disease, and obesity. And immunocompromised patients who are on therapy for rheumatological conditions may be at greater risk for respiratory infections, especially those rheumatological patients who have a background history of damaged lungs. Most rheumatological conditions are immune-mediated and characterized by inflammation, and we know that the cytokine storm in COVID-19 infection also is characterized by large amounts of inflammation. However, there was a study done in New York, a case series of 86 patients early in the pandemic with immune-mediated inflammatory diseases. There were 72 ambulatory and 14 hospitalized patients. And the study was interesting that it showed the incidence of hospitalization amongst patients with immune-mediated inflammatory disease was consistent with the general population, which means that these patients were not at greater risk for hospitalization and for severe disease as compared to the general population. And I must stress that this was done early in the pandemic. Now, how do we approach our inflammatory mediated diseases patients who are exposed to SARS-CoV-2? Ensure when the patients are exposed to the virus, hydroxychloroquine or chloroquine, salazoparin, and non-steroidal anti-inflammatories, if the patients are on those drugs, may be continued. Whereas immunosuppressants like non-interleukin-6 biologics, the JAK inhibitors should be stopped temporarily. pending a SARS-CoV-2 negative result, or at least 2 weeks after the last symptoms. The panel that drew up these recommendations were uncertain regarding temporary stopping of methotrexate and leflunomide purely on exposure. So we have to individualize these patients, and the treating physician needs to decide whether to continue methotrexate and leflunomide in this situation, or merely stop it until the patient is asymptomatic or doesn't show any symptoms after 2 weeks. In select circumstances, part of shared decision-making process, interleukin-6 antagonist may be continued. If the patient is SARS-CoV-2 positive, regardless of the COVID-19 severity, hydroxychloroquine or chloroquine may be continued, but other immunosuppressive therapies like salazoparin, methotrexate, leflunomide, and other immunosuppressive therapies except interleukin-6 biologics should be stopped. For patients with severe respiratory symptoms, non-steroidal anti-inflammatories should be stopped. However, there's a low consensus with regards to stopping NSAIDs in the absence of severe symptoms. In certain circumstances, as part of the shared decision-making process, interleukin-6 antagonist may be continued. Now, this is basically our protective and a pathogenic response to immune response to the human coronavirus. On the one hand, we have a protective mechanism where there is early interferon gamma response and there is non-robust virus replication, with the results that there is recruitment of monocytes and macrophages as well as neutrophils. There's activation of the innate and adaptive immune system, and the consequences are minimal epithelial and endothelial cell apoptosis, reduced vascular leakage, and with the result there's protective immunity and host survival. Now, patients who have severe disease, they have a delayed interferon gamma response, and because of the delayed interferon gamma response, they have robust viral replication with marked infiltration of activated monocytes and macrophages and neutrophil, with a large volume of pro-inflammatory cytokines, which leads to tissue damage, acute lung injury, ARDS, and eventually death in some patients. So these are the two types of responses that one may get to human coronavirus. And basically, one is the early interferon response and one is the late interferon response. Now, disease-modifying anti-rheumatic drugs in rheumatology patients are a double-edged sword, because some of the drugs are used to treat rheumatology patients are also used to treat COVID-19. However, some may be detrimental to the infection and cause rapid progression of the infection. So we have to weigh the benefits and the risks of continuing therapy, disease-modifying therapy in these patients. The cytokine storm, from a rheumatological perspective, we know that the disease begins with a fever and non-specific symptoms, and eventually progresses to cardiovascular, pulmonary, renal involvement, and sometimes neurotoxicity. And it is multi-system involvement, similar to some of the rheumatological problems. So the rheumatologists are quite au fait with multi-system disease and cytokine storms of a different kind in rheumatology and patients like systemic lupus erythematosus. So some of the targets, potential targets to counteract the cytokine storm, we know once the virus binds with the ACE2 receptor, it undergoes endocytosis, it activates nuclear factor kappa beta, which then causes the cytokine storm by releasing large amounts of interleukin-6. It also, the JAK-STAT pathway activates nuclear factor kappa beta in the nucleus, and that also causes the cytokine storm with the release of large amounts of interleukin-6. And that's why these patients have high interleukin-6 levels. And we have different drugs that may be beneficial in the pathway of this disease. And we know baricitinib is being used, tocilizumab is being used, and there are reports of canakinumab and anakinra being used to treat the cytokine storm in patients with COVID-19 infection. So the potential of JAK inhibitors are the new drugs on the block, and baricitinib has been shown to be of some benefit An article published in the New England Journal of Medicine shows Paracetamol to be effective and improves outcomes in patients with COVID-19 infections. I'm not going to spend too much time on that slide, but this dexamethasone slide shows that dexamethasone administration to patients with COVID-19 infection does improve 28-day mortality, and it is being routinely used in patients with severe infection. The important thing at the moment is vaccinations and immunomodulatory therapies, because a lot of people are getting vaccinated, and there is a lot of anxiety amongst patients and physicians alike regarding the relationship of COVID-19 administration in patients with rheumatic muscular diseases. So it's important to understand that with paracetamol and non-steroidal anti-inflammatory drugs, assuming that the disease is stable, we hold the anti-inflammatories for 24 hours prior to the vaccination, and there's no risk for post-vaccination treatment. We can continue the treatment post-vaccination to treat their symptoms. Timing and consideration for chloroquine, apremilast, intravenous immunoglobulins, glucocorticoids, including prednisone equivalent of less than 20 milligrams a day. There's no modification either to the therapy or vaccination timing. So patients on this can be vaccinated at any time and do not have to stop their medication. Also, other disease-modifying agents of rheumatic treatment, sulfasalazine, leflunomide, azathioprine, cyclophosphamide, the biologics like tumor necrosis factor alpha, B inhibitors, interleukin-6 inhibitors like tocilizumab, interleukin-17 inhibitors like secukinumab and ixekizumab, as well as interleukin-12, 23 inhibitors like ustekinumab. There is no modification either to the therapy or the vaccination timing. So patients on these medications can be vaccinated at any time with continuation of their medication. However, prednisone equivalent to 20 milligrams a day for more than 4 weeks, consensus has not been reached on vaccination timing. It lies in the decision of the treating physician, as well as shared decision between the patient and the treating physician. Mycophenolate mofetil or Cellcept, assuming the disease is stable, we hold for 1 week following the vaccination. So we don't administer the drug for 1 week following the vaccination. So these patients can mount an appropriate antibody response. Methotrexate, we hold for 1 week after each dose, each of the 2 doses of the mRNA vaccine, and there's no modification to vaccine timing in these patients in well-controlled diseases. So a patient who is on methotrexate does not have to worry about the timing of the vaccination. However, we omit that for 1 week after each dose of the 2-dose vaccine. And if the patient is going to take the Johnson & Johnson or single-dose vaccine, we omit the methotrexate for 2 weeks after the vaccination. Intravenous cyclophosphamide, we have to time the cyclophosphamide administration so that it will occur approximately 1 week after each vaccine dose, wherever feasible. Rituximab is an important drug in the management of rheumatological conditions used to treat rheumatoid arthritis, as well as systemic lupus erythematosus. And generally, assuming the patient's COVID-19 risk is low, so that the vaccination series may be initiated approximately 6 to 8 weeks prior to the next scheduled dose of rituximab. Now, rituximab is given in 2 doses every 6 months. So we time the vaccination for approximately 8 weeks so that the 6 weeks dose, the next 6 weeks dose is about 2 weeks prior to the next dose of rituximab. So in summary, our knowledge gains have been achieved at a tremendous pace over the last 6 months with regard to COVID-19 infection and rheumatology. Importance of good disease control is absolutely important, because remember, patients who are poorly controlled have increased cytokines by themselves, by the disease. And if these patients get infected, they are more likely to have worse outcomes. Importance of risk mitigation. Emerging data, the landscape is continuously changing in COVID-19. However, commonly used target therapy are not always as likely as initially thought to render patients at higher risk or at a greater risk of morbidity and mortality. So we have to individualize and tailor treatment to fit each patient. And advances have been made in our understanding of new therapies for COVID-19 that can improve outcomes, not only in rheumatology patients, but in the population at large, so that overall our outcomes are improved in rheumatological and non-rheumatological patients. Thank you very much, ladies and gentlemen. I hope that brought some clarity to COVID-19 and rheumatology, and it allayed some of the fears that physicians have with COVID-19 and rheumatological patients. As we know, rheumatology is a very complex disease subspecialty, and it can be quite daunting for the non-rheumatologists. Thank you very much, ladies and gentlemen.